Good afternoon, everybody. At the outset, I should thank Dr. Suripta Mitra for giving me this opportunity. So, no financial interest. I will just focus on these points: the IOL implementation, this primary, secondary, IOL types, and IOL power selection and target refraction. Most challenging part of a pediatric cataract surgery. So, primary for IOL implantation, most of us go for IOL implantation more than 2 years of age. Less than 2 years, increasing number of surgeons implanting. I have implanted IOL in 8 months of age, but less than 6 months usually we don't go for it because of the complications. And for the IOL size, for 2 years or more, we usually give the adult size. For less than 2 years, we usually go for this white to white corneal, horizontal white to white corneal diameter, and give the overall diameter of the haptic 1 millimeter more, so that it can snugly fit into the sulcus. Secondary IOL implantation is also a safe and effective alternate. It's correct aphakia in contact lens and spectacle intolerant children. For this, also in case of traumatic cataract, in first we cannot go for IOL implantation. After the eye becomes quiet, we can go for secondary IOL implantation. Now, types of IOL, most of cases we go for hydrophilic acrylic single piece IOL. Multi-piece IOL sometimes we give. Multi-piece IOL also we can give when first we have done a lens aspiration and primary posterior capsulotomy, anterior vitrectomy, a small child. And then when the child grows and the anterior posterior capsule becomes so attached that we cannot separate them. So then in that case we can go for multi-piece IOL, because we cannot give, we cannot put that, we cannot separate the anterior posterior capsule. And single piece should not be given in sulcus, especially in children. SF IOL we also give for congenital lenticular subluxation in some cases, like in congenital rubella, when we go for total lensectomy and vitrectomy in later age. If we are sure that there is no viral infestation or something, we can go for secondary SF IOL, or in case of traumatic cases. So advantage of hydrophobic IOL, their ability to inject through very small wound. The haptics unfold very slowly, so it can be given up even after the PPC is done, even in large PPC. It has got a very good memory. Where it is given, it stands there. It does not rotate. Lower rates of PCO and lower rates of IOL opacification. And most important for the children, less rate of postoperative inflammation. We usually don't give yellow-coated lens. We give white lens. These are few contraindications of IOL. Absolute are usually severe microcornea, microphthalmos, when the eye is too small, less than 9 millimeter diameter, horizontal white to white diameter. I usually don't go for this lens. And there are some relative contraindications. So most problematic is this IOL power selection and target refraction. These are the problems with pediatric IOL power calculation. The axial length keratometry measure errors due to non-cooperation and fixation errors. And all the things are instruments designed for adult eyes. Target diffraction and myopic sheet is also causes a problem. So it is a practical difficulty. Lack of fixation under anesthesia may lead to inaccurate keratometry reading. Need for a handheld automated keratometer, which is not present in all the institutes. And we need a very good experienced biometry person who has the idea or knowledge or training for this pediatric biometry. Choosing the right formula of IOL power calculation is also a challenge, because all the things, these are for adult formula. So it is not good for 2 to 17 years of age. In our institute, for cooperative child, for optical biometry, sorry. Okay. One second. So these are our postoperative refractive M. We usually go for moderate plus, not 0 or not high plus. And these are recommendations for IOL power selection. So for emmetropization, we mostly go for this Dahan and this one. And so take-home message is the IOL is the best choice for treating pediatric cataract. Selection of optimum power is multifactorial decision, and cataract surgery is but the one step on long road to visual rehabilitation, not the end of the journey. These are my references.
Thank you so much, Debajit. We welcome our chairperson, Dr. Partha sir. In interest of time, before we go to the next topic, we take a question from one of our panelists who is also present, Dr. Manpreet.
So, for the esteemed panelist and chairperson, I have one question. What's your take on premium IOL in pediatric cases? It's a controversial topic even now. So, what's your take on that?
For me, it's an absolute no. In pediatric age group, it's absolute no. And I think that's it.
Torics above the age of 7 or 8. And a few questions for you because you're from the premium institution. If the child is on the myopic side and between 2 to 5, do you do PCC or?
I do a PCC, sir. Vitrectomy, I might leave if I feel it's too liquefied, but PCC I'll still do.
And Dr. Chatra, from the retina perspective, would you advise?
Given the fact that they're still in the amniotic age group, so
And-
we would still prefer that it's done, and if the anterior face is intact, prefer better not to touch.
Yeah.
Can I just
Most of them have a formed vitreous,
Yeah.
and the anterior face is intact, so you don't really need to do anything. You can just do a gentle, PC opening in the center. That's more than enough.
But then you are leaving behind the scaffold.
Yeah, but if you breach the anterior hyaloid face, it becomes really messy. The inflammation becomes more. So unless you're very confident of doing a good anterior vitrectomy without any vitreous actually coming anterior, then
You're leaving, huh?
because that keeps a barrier to good enough.
Chatra, carry on.
I was saying that's up to the
Operating
neatness of the procedure. What I'm saying is, if you are doing a PCCC without doing a vitrectomy, the anterior hyaloid face remains as a scaffold, and the peripheral marginal epithelial cells can regrow and perform and actually produce a blockade or a blockade of the PPC opening very, very fast indeed. I mean, we are talking about a 2 to 5 years of age group. So, in my opinion, if you're not going to do anything, don't do anything. If you're doing a PCCC, then you should be doing a need vitrectomy associated with it.
And I would quite agree with
Yes,
this.
sir.
And the plaque or the epithelial cell that grow over a hyaloid phase is much more difficult to YAG than a PC which has opacified. Anyway, a PC which has opacified is really very difficult. So a membranectomy has to be done through the posterior route. But I think neatly done PCC and an anterior vitrectomy just as much as is required.
But what happens most often, of course, for you guys, it's okay because you'll be doing it very often. A lot of them tend to do such an incomplete job that we have to go and complete it.
Yeah.
It's very, very messy. They're speaking,
Yeah. Yeah.
Okay.
What
Question.
Chaitra said. Now, it was at one point of time that the manual capsulorhexis used to be done for the PCC. I still do it in my cases, but now it is easier, and people who are getting initiated to go by the vitrector after placing the lens in the bag and do a posterior capsulorhexis or a posterior capsular opening, and then an anterior vitrectomy, and then place the lens back.
Very practical points
last
discussed.
question, because this was missed. Dr. Manpreet, how often do you check the IOP of the patient because that is something which is the most neglected part?
You have frequent examination with the anesthesias. So initially monthly. So the first EUA is after 1 month unless there is indication to perform it earlier. And at that time we do suture removal and IOP. After that 3 months, then 6 monthly till I decide to implant an IOL if I've left a phakic, or the child is old enough to allow a slit lamp
So
examination.
you subject the child to EUAs
Yeah. Yes, sir.
without any?
Serial EUAs under mask.
Yeah, that's that.
We do subject them to serial EUAs. Yeah.
Sorry.
Discussion is no, sir. This is such an interesting topic and so much to learn, but the time is limited. So just we go on to our next topic, and we quickly hand over the token of appreciation, ma'am. Sir, can you please come?